So, respected Chair, I thank the AIOC for this kind invite. I understand that this session is 55 minutes and we have 9 talks. So, I'll try and cut down my talk to about 5 minutes. So, this is a dying art, a scleral buckle. And this art entirely depends on another art, that's the art of indirect ophthalmoscopy, where you can meticulously try and find out all pathologic breaks using dynamic ophthalmoscopy. And I think the most important to understand which is the primary break causing a detachment is the knowledge about the Linkoff's rule. Traditionally, we have been doing this fundus drawing on the Namsler's chart, but nowadays, with the advent of a wide uh, fundus imaging system, you could get most of the images, all the breaks covered, even without a detailed fundus examination. The indication of scleral buckle typically is for young myopic, phakic patients with PVR less than grade C, but nowadays it also depends more on the surgeon's preference. The aim of the surgery is to indent the sclerochoroidal complex inwards so as to support the break and prevent the connection between the vitreous and the subretinal space. The first step in this after localization is creating a retinopexy. Historically, it was with the diathermy, but now we have moved on to cryotherapy. But there could be occasional cases where you might do in the first post-operative day a laser photocoagulation. The final strength of all of these modalities remain the same. Non-absorbable buckles are the norm nowadays, and these could be tires, bands, or the sponges. Tires, both the depending on the location of the break from the muscle insertion, you could choose any of these. The odd number tires have a central groove, whereas the even ones have the eccentric groove. And then you also have the sponges, which are predominantly used for as a radial buckle, but the usage is relatively less because they have a higher incidence of exposure. So the preferred choice generally is a circumferential tire, usually along with a encircling band. So can I have the video? Yeah. So there are two techniques for this buckle surgery. One is the, or if you can play it separately. No, not the drainage. Can you the other one, the implant? Yeah. So typically, the implant is where you dissect the sclera, and this is the technique that we used to do about 3 decades ago. Very elegant surgery. You can actually, based on the dimensions of the buckle used, dissect the sclera and then pass the sutures. This also helps in the choroidal drainage because you have a very thin scleral bed. But obviously, it's more time consuming. Can we go on to the PPT? Can we go on to the PowerPoint? Can we go on to the PowerPoint presentation? Again, the next most commonly preferred technique, I think we'll skip the videos, we'll just go to the PPT. Is what's now the preferred technique is the explant technique, which is much more simpler, where you place the desired, after localizing the break, place the buckle and then take the sutures through the sclera without doing any scleral dissection. And our study way back in 2003, comparing the implant and the explant technique, showed that the surgical and the anatomical results were the same, though the risk of long-term exposure was slightly higher with the explant as compared to the implant technique. The most important step in a buccal surgery then becomes the drainage. And the dictum is most surgeons drain most of the detachments most of the time. Though I know this is one of the most fraught with complications step. The drainage is done under the scleral bed because you would ideally want, even if there were a complication of a retinal incarceration or a vitreous loss, it would still be supported by the buccal. It's done in the most bullous part of the detachment, but again away from a large retinal tear because you don't want the vitreous fluid to gain access into the orbit. So again, I'm not able to show the video itself. So as I said, the drainage is the most dreaded complication procedure here, and it could be complication of a subretinal bleed, choroidal bleed, a retinal incarceration, and a long-term even a neovascularization developing from that side. So buccal surgery is not without its failures. Failures could be because of a misplaced buccal itself where the break is not completely tamponaded, and also it could be because of missed break, new break formation, or PVR, which is more common when you do extensive cryo in such cases. So in conclusion, the success of a buccal surgery purely depends on a good clinical examination and the decision itself to do a buccal for such cases. And believe me, those cases which are amenable to buccal actually have a better anatomical and visual outcome as compared to vitrectomy in such cases. So before I conclude, I invite you all to this Retina Summit 008, which is on crisis management. This will be on the 9th and 11th of July. Thank you.
Thank you, Dr. Girish. Nice presentation. Please. So, whatever he was telling that highlighted that is the most important step in buccal. It is drainage, external drainage, and the first thing, accurate localization of all the breaks. When we are used to draw all the diagrams, that was much more like, maybe it is very much tiring, but it helps in pre-operative diagnostic, like kind of, it is almost kind of optos like wide field and photograph situation that we are highlighting all the breaks. Even the tiny breaks you should not miss.
Yeah, and we use the clues of the vessels.
Yes.
The trajectory of the vessels to actually lead to the break.
That also helps that if the number of breaks are is much more, you can shift your, like from the buccal to where you can decide whether it is not possible with the buccal alone and at the multiple meridian. So for young patient with clear lens, so buccal is the choice. That is.
Yeah.
Thank you. Thank you, sir. With that, we have to interject, and thank you, Girish, sir. There's a rejig of the program. We now have Dr. Subhadra Jalali, madam. She's going to be speaking on pediatric macular surgical techniques, and this will be followed by Dr. Hemant Murthy, sir.
Thanks for having a stool for ladies, and also thank you to the AIOC for having me here. So I will be talking about pediatric macular surgical techniques. I think we are all talking of macula, but we only talk of macular hole, ERM, and nobody talks of the pediatric macular surgery. So can we have the slide moving, please? Okay. So what is different in macular pathology in infants? I think this is very important to understand that the macular configuration of the disease depends on the persistent fetal vasculature stock, which I will show in different pictures. The second difference is that the infantile macula, unlike the adult macula, can stretch as it is elastic, just like you have a ophthalmos in a congenital glaucoma, which doesn't happen in adults. The other thing is that all these conditions where there is a macular involvement, they are usually progressive, and so the vision and the vision potential keeps on progressively decreasing. Here is an example of retinal detachment in an ROP. You can see the first picture shows there's no PFV stock, so you will have a stage 4A. It will not form a fold. But the moment there's a PFV stock, then the retina will drag, and what you will get is that fold. That is how the fold forms. And this is not restricted to ROP. You can see here two cousins with the same mutation, how the eyes look different, why the disease is different. Because you can see that when there is a PFV stock, it will form a fold and a large falciform fold, or what we call as a volcano detachment. If there is no stock, then it will be flat and dragged only to the periphery. Same way happens in Coats retinopathy. You can see the first one, there is no PFB stalk, so you can see the macular disc separate. But in the other one, you can see the arcade has narrowed in a Coats disease because there is a PFB stalk and the fovea is getting affected through that traction. This is hamartoma. So in the hamartoma, if there's no PFB stalk, you may not get a big fold, but if there is a PFB stalk, then you'll get the fold. So this is FEVR. You can see again there's a PFB stalk and how the exudates come around that. And in this case, because the stalk was densely adherent to the central retinal artery and to the fovea, we only trimmed it. We didn't dissect it out because that would be disastrous. So I think I can just show this video of how this talk helps and how we manage. Can we have the audio also? So this is a case of hamartoma.
And try to look at the areas where we can find a edge where we can lift the epiretinal membrane. So here we are seeing now that there is a vitro membrane adhesion. We found the edge and there was a good edge here. You can see the ERM is between the
So this is where the stalk
drag
is.
disc and the fovea and the surrounding macular area. We are now using sequentially the end gripping forceps and the vitrector to lift and create a plane between the membrane and the underlying hamartoma and the retina.
Stalk here.
Usually the membrane does come out quite pretty well easily. It's not very adherent, but there would be retinal folds under that membrane, and that is what we have to be very careful about. So the retina would be thrown into undulating folds under the membrane, and we should be very careful. But otherwise, as you saw, it does come out pretty easily, and it's not very difficult to remove.
So we have to be patient and remove it slowly, because sometimes the adhesion is very tricky at the fovea and you can create a foveal break.
This video is of a 3-year-old child where we are doing vitrectomy for FEVR fold. So I wanted to depict how to manage the retinal fold and the persistent fetal vascular, which is very often associated with these folds in FEVR cases. So as you can see here, there is some vitreous hemorrhage, active vitreous hemorrhage, and that is the reason why we are operating this case. Many people would have just done a laser, but that doesn't work because, as you will see in the video, there is a lot of vitreous covering that avascular retina. So we are trimming this persistent fetal vasculature stalk, which is going from the disc to the periphery. Near the fovea, there will always be a very dense attachment. You can use a scissors or a bimanual technique, or if you are deft, then you can definitely release that traction slowly around the fovea, as you see here. So there will be a stalk and there will be surrounding vitreous which is causing that fold. Be extremely careful not to eat away that fold of retina and create a disaster. So slow trimming of the stalk, which will relieve the traction.
So let's see one more. This is a Coats disease with the PFB stalk. I want you to see the plug formation, that a small plug will come out here. You see this white part, this is the PFB stalk. Sometimes we don't understand that this is the PFB stalk. We think this is just an ERM, this is a scar tissue. So this is a PFB stalk. Just see, I'm just trying to very gently move it because I need to assess, is it through and through? Then I have to just trim and leave it, or is it a plug which I can detach? So I'm not pulling it more, so I have trimmed it. If you want to use bimanual, you can use bimanual, but I'm using single. Again, I'm trying to see under it, is it going through and through, or will it come like a plug? So you can see it has tentacles, and slowly, if you release it, you can see that it will come out like a small plug. So you can see that plug. See how it is? So it just comes out from that fovea. So that's how you should manage. So to conclude, the macular surgery of infantile onset retinal detachments should take into account the variable disc and foveal adhesions of the PFB stalk, which causes the retinal folds. These disc adhesions can be of variable extent. It can be at the center of the disc, it can be any edge, mostly temporal, but sometimes can be nasal or inferior, and it could be adherent to the central retinal artery. The foveal adhesions could be like a surface plug, a deeper peg. It can have satellite type of configuration with thin tentacles, or it can be adhesive with the full thickness scar tissue. In the last case, we only trim it, but we don't detach it because then there will be a large macular hole. Thank you.
Thank you, ma'am. Thank you for finishing on time. Great talk. I'll request Dr. Hemant to be there with this talk. I just had one question to you, madam. Any quick pearl or trick as to what cases of a combined hematoma with the ERM should one operate, and what would be one or two differentiators from a routine ERM surgery as opposed to the ones associated with a combined hematoma?
Yeah, so the most important thing is to know whether the traction is vertical and it's going to pull it up, or as I showed here, there's a persistent fetal vasculature stalk which is going to pull it if the eye grows. So if let's say it's a 10 or 12-year-old patient, then we know that this eye's growth is almost complete. So it's not going to cause more traction. But if it is at a 2-year-old or a 3-year-old, where the eye still has to grow. So sometimes if you're not sure whether you should operate or not, of course we always do OCT to look for the traction, to look for the vitreous, but then you can call back in 3 months and see. Always take photographs, always do OCT, and you will know that this is progressive, and immediately we should operate. If it is already showing traction and there's thinning on the sides and you can see a ring where the vitreous is getting pulled up, then you should operate.
Thank you. Ashish, one quick comment.
Yeah, no, so ma'am, I just wanted to ask, does ILM peeling over these retinal folds help in allowing that fold to go back in the post-operative?
So some people do that. They use Brilliant Blue. Some people also use Tramslone. I usually stain it with Brilliant Blue if I think that there is a membrane on it. But we can do that around the macula, but we don't do it in the periphery. The fold will extend to the periphery, but if you release the posterior part, you don't have to do anything to the periphery. So less is more in pediatric surgery.
Thank you, madam.
Okay.
With that, I come to Dr.
I'm
Hemant.
on the other side, and I'll come back if you need me.
Yes, with Dr. Hemant with his talk, and I request Dr. Vivek to be ready on the fellow podium, please.
Thank you. First of all, let me thank Dr. Piyush and the scientific committee for this opportunity. I'd be talking on to you with something of very basic in nature about how do you induce a PVD. So generally, whenever you start your surgery, a cutter is more than adequate to induce a PVD in majority of your cases. And it tends to be fairly, then you start with the disc and then proceed to the periphery, and you can separate it with just the cutter alone in majority of your cases. Now this was a case of a patient with VMT, and you can see that in spite of numerous attempts, there has been no separation from the retina, and you just cannot induce the PVD in this situation. So these are some situations wherein I feel, you should start going back to what we learned. We tried with forceps, nothing seems to work. And then I go back to the soft tip cannula. This is probably a very good use of a soft tip cannula to induce PVD, because you're able to now get a small separation. You can actually see the wave of separation that occurs as you go along. As you keep dissecting, the waves goes along with it. And once you get a reasonable separation, you can actually then start, inducing the PVD. So using a soft tip cannula, I would suggest all of us go back to it in difficult situations. So in this patient, actually after that, once we could get a separation, I actually used a small pick, made a small opening so that I can separate it from the macula so that I don't cause any traction on the macula. And once that is done, you can actually release it completely from the. So this is one way of how you could induce the PVD using just the soft tip cannula. Now you can see how easily it comes out. Now occasionally we have, you start with the nasal side of the disc and you see that you are able to induce the PVD. But the temporal side doesn't come out. You have schisis which occurs there, and you need to now meticulously remove it from the retina. So this is one other situation wherein you have to be alert that there could be differences in the way the vitreous separates out from the macula. This is another patient of VMT. So there was a small separation. I did use a pick to make a small opening in between the macula and the disc. And then using the Tramslone, you can see the opening now. I went around the macula to separate it from the attachment so that I don't cause any traction. In this way, you can clear it and safely remove it without having any trauma to the macula. And then you complete the PVD. Now, in myopia is one condition in which you should remember that you would have to use triamcinolone repeatedly because there is a very frequent occurrence of vitroschisis. So keep looking out for this. You might see a V ring, but that's a very false appearance. You have to keep staining it again and again. So repeated staining will probably be the way out for in myopia. And unless you induce the PVD completely, you would not get attachment in a patient who has got retinal detachment. So you have to be very patient and do it multiple times to be able to release the PVD. Now, this is a patient of retinal detachment, and you would assume that PVD has occurred, and this is how the patient has the detachment. But once you stain it with triamcinolone, you actually see the posterior vitreous cortex still adherent. And this needs to be removed meticulously. So you can see how it's everywhere you would see the same thing. So you need to go ahead and keep removing it as you go to the periphery. And once I remove it around the posterior pole, I put in PFCL and then proceed to the periphery after I use the PFCL. Now, in diabetics, you could induce induce PVD in small, increments. So you induce a small area of separation because there could be attachments at various points. So use the suction to elevate a bit of the vitreous, excise that, then go to the next clock hour, then excise that. So you go in incremental fashion in diabetics, not trying to do how you would do in any other patient of, let's say, ERM or a macular hole. So this is how we proceed in a patient with diabetics. Now, what would happen if this is missed? This is a patient of recurrent retinal detachment. And when I stained it with triamcinolone, actually you can see that there is the entire vitreous is still present. So that's the basic cause. You can see it just comes out. So these are, you should look out for all these conditions. And I think frequently it gets missed. And that's wherein we start developing complications. So a simple step in surgery is so critical to our outcomes that one needs to look out for it and proceed appropriately. So in conclusion, I can say that, a lot of it has changed. You use triamcinolone, don't hesitate to use it to identify the vitreous. Vitroschisis is very common, especially in the young, the myopes and the diabetics. Use of a soft tip cannula actually can help you in very difficult situation. I think you should go back to how we started inducing PVD. I think it's a very elegant technique. And a pick is a very useful tool, especially when you come across a VMT to separate the attachment to the macula. Thank you very much.
Thank you, sir. Great talk. And I think just emphasizes the point very, very well that the fundamental of vitreous surgery, which is vitreous removal, is the cornerstone. And there's no absolutely, no stone should be left unturned to try and ensure you get the vitreous out, sir. Thank you for that.
Thank you.
Thank you,
excellent
Dr.
masterclass on that.
Thank you, Dr. Hemant. I want to add one more thing. Like sometimes in pediatric retina detachments, the vitreous is very much sticky to the detached retina. In those situations, after doing the all vitreous removal, you can just stain this membrane with this triamcinolone, and you can use DDMS or Phoenix loops to separate this, induce the PVD from the disc margin, and inject PFCL, then again detach. But fantastic demonstration of all the PVD induction. Thank you, sir.
Thank you.
Thank you. With that, can I request Dr. Vivek for his talk, please? And I believe Dr. Abdul Rahman is not there, so this will be followed by Dr. Mudit's talk. Yeah.
Full screen otherwise. Thanks, Mohit. The timer is on, but the screen is not. Timer पीछे करिए. Thanks once again. Good afternoon, everyone. The topic allocated to me is an innovation-related one, which is driving innovation in surgical retina with new pump fluidics called VTI pump. These are my financial disclosures. Now, we'll take one step back to the previous lectures that we heard, and we talk of vitrectomy in terms of vitrectomy being a core step in retinal surgeries, and it requires precise control to have safe and effective results. So how does one optimize our outcomes? We do it by mastering the understanding of our machine and our fluidics. Now, if you think of fluidics, the amount of literature that is present out there on fluidics and with all the physics that is involved, for the surgeon, sometimes it can be a complete brain fade. So what is important is to go back to basics and understand that when we talk of vitrectomy, we talk of a closed system in the eye, which is getting infused with a pressure, and there is a machine which under vacuum is taking the vitreous out. And in this interplay, as a surgeon, you want this thing to happen without globe collapse, smooth without any jerks, at a pace which is comfortable to you as a surgeon, without undue retinal traction and without undue vitreous traction or turbulence. Now, traditionally across ophthalmology, be it phaco, be it vitrectomy, we have the peristaltic pump and the venturi pump. We know that the peristaltic pump has flow induced by a rotational speed of the pump, and here there is a big safety margin. Whereas the venturi pump is something which is a quicker system. It has flow induced by vacuum changes, and this is touted to be more efficacious, and the trade-off might be a bit of safety. So when you look at the VTI or the vacuum flow or the vacuum timed infusion flow, which is present in the DORC-EVA Nexus, it is sort of the best of both worlds. So instead of having a pure peristaltic or a pure venturi system, here we have a micro chamber with computer controlled pistons and valves. So this is something like this complicated sort of robotic diagram. But if you see, there is a roller peristaltic pump part of it, and there is a compressed air venturi pump part of it, and there is this central section which sort of incorporates both the technologies together. So if you look at the VTI pump vis-a-vis a traditional peristaltic pump and a traditional venturi pump, and hold them up against each other on basic characteristics that we look at as a surgeon, which are the flow characteristics, which is the flow stability or the vacuum control or the response speed of the machine, it will show us that the EVA Nexus VTI pump sort of scores in all of these sort of subheadings. So the overall advantage of this pump is giving the surgeon a continuous flow, irrespective of what is the type of material that your cutter is dealing with, be it air, be it fluid, be it PFCL, be it oil. You are going to get a constant flow while you're operating on this system. And thus there is downstream an adequate or an appropriate vacuum control. That means you are not going to end up pulling any tissue inadvertently suddenly. So when you look at the flow mode, so the machine will allow you to select between the vacuum mode and the flow mode. If you look at the flow mode, here as a surgeon, when you go to the flow mode, you control the flow. The control precision can be as low as 0.1 ml per minute, and this allows you stable aspiration even when there is occlusion. So you are not going to feel a surge when the occlusion breaks. So this can be used for vitreous shaving near the retina, or ILM or membrane work, or delicate maneuvers which are very close to the macula, like say vitreomacular traction removal, which was shown in the previous presentation. So this sort of mimics the control characteristics of a peristaltic pump. As against that, when you shift to a vacuum mode in the machine, you will have a rapid vacuum rise time. This is effective for a bulk removal of vitreous. So I would say for core vitrectomy, it is a good sort of mode to work on. And this can also be used to engage tissues or fragments as, say, a dropped nucleus. So this would mimic the response characteristics of a venturi pump. So you can also have a step-based switchover when you operate. So when you start with core vitrectomy, you can start with a vacuum mode, take the advantage of greater pull on the tissue. When you move towards the periphery, you can go to a shave mode, and you shift to your flow with about 6 to 10 cc per minute, which gives you good control. And if you have mobile retina or thin retina, to ensure that you do not engage it, you can bring down the flow to about 1 to 3 cc per minute. So there is also something called as a smart IOP function, which ensures that a constant intraocular pressure is maintained irrespective of what is the step of surgery you are doing, be it aspiration, be it occlusion, be it the moment where occlusion is breaking. During all these situations, the smart IOP function ensures that the IOP remains stable. So these are the different situations that one may encounter based on the type of tissue that you are dealing with. And as you can see in the graph below, everywhere you see that the IOP remains largely constant because of the machine adjustment. So this is like a clinical example. So suppose your target IOP that you want is 20 millimeters mercury. But then physics-wise, the machine will calculate that the expected loss due to, say, height difference is 5 millimeters, tubing resistance is 10 millimeters, and so on. So it calculates that the total loss is about 20 millimeters mercury. So the machine maintains a pressure of 45, which gives you your effective pressure of 20. So this constantly keeps happening dynamically to ensure that you are always maintaining the normal pressure that you want. So now I will just quickly go to TDC, or the two-dimensional cutting system, which is also working in analogy with this system, which is a procedure where, or which is a cutter where the inner piston actually moves like a cutter. So you have a cutter within a cutter, which ensures that you are cutting the tissue appropriately well. So in conclusion, in modern vitrectomy, maximum control is more important than maximum suction. While speed removes vitreous, stability protects the retina. And the VTI pump actually transforms vitrectomy from a suction-driven system to a precision-controlled surgery. Thank you so much for your attention, and we hope to see a lot of this audience in May in LVPI.
Thank you. Thank you, Vic. Great talk. Very succinct. Just anyone who has experience with this machine, one quick point just to add or support or detract from what Vivek said.
No, Doctor. I have not used this Dork EVA machine, but I have used the Unity machine, which is having running on the mode of like peristaltic pump. It's a peristaltic pump, but you can switch to the vacuum pump, because in the peristaltic pump system, what is the main difficulty when you are trying to remove some kind of clot from a detached retina? With the foot pedal control, it will not take out that clump of the blood. It's not so easily. So you have to switch on to the vacuum system, so that you can foot pedal is more you press, more you get the suction to lift up the clot or some kind of smaller fragment from the detached retina. So it is helpful. The vacuum pump is like Venturi pump is helpful, but Dork EVA system has the dual pump system. That is the mainly it is peristaltic. You can switch on the vac, but rarely in Unity mainly it is peristaltic. Sometimes you can switch on to, but your assistant should switch the mode to the Venturi system.
Yeah.
Thank you.
Thank you.
Thank you, Dr. Vivek. Dr. Mudit, please. And you had a comment to make if you want, quickly.
Question, but I'm done.
Fair enough. Thank you.
All right, so good afternoon. First of all, let me thank the scientific committee of AIOS for having me here, and to our chairs of this session. So I'll be talking about retinal detachments in viral retinitis, essentially acute retinal necrosis and CMV retinitis. Now, detachments in viral retinitis are a complication and can occur in nearly 40 to 60% of patients with ARN. And RD rates of 8.7 per 100 eye years have been documented in some of the studies for CMV retinitis. Now the problem is that for both ARN as well as for CMV, you can have a rhegmatogenous as well as a tractional component. And most of the times these detachments happen in a healing stage when the peripheral retina becomes necrotic. So unlike a conventional retinal detachment that we see the simple RDs, ARN and CMV retinitis get complicated by extensive peripheral necrosis of the retina. So surgeries in these conditions have got some different challenges and some different aspects as compared to a simple reg RD. You are first of all dealing with a pre-existing retinitis. So if there is an extensive pre-existing retinitis, the first thing that you need to do is differentiate whether you are dealing with an exudative RD or a reg RD. Look carefully for breaks, look for areas of necrosis. If there is extensive active retinitis, you also need to take care of that apart from taking care of the detachment. The vitreous is slightly different, more thicker, more densely adherent in these eyes. And let me show you what we are talking about. So this is how you see this thick sheet of vitreous over there. This essentially is how the vitreous in eyes with ARN and CMV behaves. Extremely thick sheets of vitreous. Some of them are very densely adherent, so you may have to take time to go and truncate. You need to be careful. You can't be pulling in the periphery, because if you do, you will end up creating more of the iatrogenic break. So look at how the peripheral vitreous adhesions are. You need to cut them as much as possible if you are not able to remove them or induce a PVD. So try to truncate or cut them rather than pulling upon them and creating more breaks. So this is what we are doing over here. You can see how you need to go and cut all of these peripheral membranes. Go close, shave those vitreous membranes over there if they are densely adherent. But do not try to be very aggressive in pulling them up, because then you will end up creating more peripheral breaks over there. Apart from that, the retina, like I said, is necrotic. So this is how the peripheral retina will behave. You see this extensive area of peripheral sieve-like retina. So that's how the retina in eyes with ARN behaves. You will see some amount of central retina which is normal, but look at how the peripheral retina is. Multiple areas of multiple breaks which can be sieve-like. Now, a lot of times people say you need to cut all of that. You don't need to cut it. Once you have settled the retina, most of these will create adhesions and there will be fibrosis and scarring over there. But you need to ensure that you remove as much of vitreous, try to truncate all of it. But this is what we were talking about. This sieve-like pattern of retina that happens in eyes with ARN and sometimes even in CMV. ERMs are the other big challenge that you have in these eyes. The vitreous is so densely adherent and sometimes you may have a very thin sheet of ERM over these eyes, and unless you are meticulous in removing them, you will end up having recurrences. Remember, the recurrences of retinite RDs in these eyes are very shallow. When you get an OCD, you will see a shallow fluid over there. The reason is that you have not been able to remove the ERM and you leave some membranes behind. So this is how one of our patients was with these thick membranes, and this is what you need to do to take care of them. You need to be careful, remove all of these membranes as much as possible, and once you remove them, you'll realize that now your retina becomes more pliable, more bullous. So take care of all of these membranes, remove them with the help of a forceps. If needed, you may need the help of a cutter to go around and dissect it. This video, I don't know why is not playing, but it's all right, I think. So this is what I'm saying. So this is another patient with this adherent ERM or this membrane over there. Until the time you remove this, you will end up having failures of your retinal detachments in these eyes. These eyes will come back with a recurrence. So carefully go around trying to remove all of these membranes. Once you remove them, you will be then able to have, like I said, more pliable of a retina over here. You've got a break over here in this area of peripheral necrosis, but you can get away with that. So this is how the patient was initially. This is what the patient became subsequently. And the one video which was not playing, which is basically about where you do a laser. So I'll just quickly just dwell upon that in brief. So what you need to do in these eyes, I don't know why somehow that video is not working, but you need to ensure that you do a laser in the area of normal retina. Try to segregate or completely isolate the area of normal retina from the peripheral retinitis area. So do a 360-degree laser in the area of normal retina. Ensure that the power of your laser is not too much, because you do not want to create multiple small breaks just because of the force of your laser. End up putting oil. The choice of 5000 versus 1000 will be based on your discretion, but if you've got just a localized detachment, probably you can use a 1000 centistroke oil. But for other cases, it makes sense to keep these eyes under silicone oil tamponade for a longer duration. So you put 5000 centistroke of oil. And luckily what we have noticed is in a lot of these eyes is that the amount of emulsification somehow is not that much as what you will see otherwise. So for reasons which are not known to us, but thankfully the amount of emulsification in eyes with CMV or ARN retinitis is luckily much less than what we usually encounter. So you can keep these eyes under cover of silicone oil tamponade for a longer duration of time. So this is what we are talking about. Once you remove these membranes, this is how the retina looks under the cover of silicone oil over here. And this patient ended up having a visual acuity of 20/80, which the patient did maintain for nearly 3 years of follow-up. So these are the points that you need to tackle whenever you take care of any patient of retinal detachment with sublying or underlying ARN or CMV retinitis. Take care of the pre-existing retinitis, identify the abnormal vitreous adhesions, take care of the thick ERMs, take care of the necrotic retina, and sometimes be prepared for recurrences. And for those, like I said, it makes sense to use a heavier tamponade, so 5000 centistroke oil. So lastly, remember that these detachments are slightly different and offer different challenges as compared to routine detachments. Vitrectomy is preferred over buckling, and you need to take care of the points that I said: adhesions, necrotic retina, and thick ERMs. Thank you.
Thank
And
you.
right on time.
Thank you, Murid. Appreciate. No questions. We'll have questions if need be after Vishali Madam's talk on PPV and uveitis. I think it might straddle some of the similar issues. And with that, I hand it over to Vishali Madam. And is Dr. Nishikant here?
No.
Thank you,
I
Mohit.
think he has already missed his flight.
So this is going to be the last talk. In the interest of time, I'm going to forego my talk also. So the other session people can be very happy then.
Perfect. Thank you. So, this is not moving forward. Sorry. Okay, perfect. I will be brief. So when we talk of vitrectomy in uveitis, it could be diagnostic. Diagnostic simply means it is undifferentiated uveitis, or you are suspecting lymphomas or malignancy, or they are not responding to therapy and you just do not know what it is. I'll give you an example. This is a 40-year-old woman referred as a case of non-responding intermediate uveitis in the left eye. So this is what her right eye looked like, and you can see few lesions out there which we did not know what they were. This was the left eye where somebody had injected Ozurdex because of severe vitreitis. This was the autofluorescence of the right eye, the fluorescein angiography, nothing very typical, or you can put your finger on. This is how it looked like. ICG was essentially normal, and this was the left eye. Now what next? We thought it could be, infectious etiology, and probably the left eye was Ozurdex induced, worsening, or, whatever, endophthalmitis, but something was not right. So this is the first thing. If things are not right, please go ahead and do the vitrectomy. Don't wait for, sorry about this. Can you make the video work? Excuse me. Can you play the video? So, anyways. So if the things are not the way they should be, it's always better to get the vitrectomy, take the samples, and okay, move on to the next slide. And this is what post-vitrectomy, this is how the media looked like, and we could not find much because there was Ozurdex in the eye. Only thing was a single atypical lymphoid cell, and we were not sure because it's a young woman which has a bilateral disease, and if it is a lymphoma, she needs systemic therapy for CNS as well. So we just waited for 2 weeks for the effect of Ozurdex to be over because it was removed in the previous surgery, and then we went ahead with the second surgery. Few steps about while you are doing diagnostic vitrectomy. First is small gauge. There is no need to reduce the cut rate to 800 and all if you are using 27G. Obtain the sample from the debris, of course, but in malignancy, the malignant cells do not adhere to each other. So if you are chasing all those debris, they might be just inflammatory debris. So make sure you take the sample from what you think is a clear vitreous. You will find pre-retinal deposits, which is very important to take on. By and large, for primary vitreoretinal lymphoma, there is no need for any retinal biopsy because the deposits are not really intraretinal. But make sure to pick up these debris on the surface and label each sample differently, undiluted, diluted, so that you know from where it's coming. And of course, it was all full of lymphoma cells. This is how the patient responds to chemotherapy. Now, besides the diagnostic, there are a lot of indications for doing therapeutic vitrectomy. And the first indication itself is when nothing is working. Because there is this beautiful image out here which shows that when there is a precortical vitreous, there is a very high concentration of cytokines which gets accumulated in precortical pocket, and that increases the chances of inflammation, and you need a very high dose of systemic immunosuppression to take care of this. Removing it by vitrectomy just lets retina breathe. You take care of the cytokines, and it's very useful for, you can get away with the minimal amount of medical therapy. Sometimes you may need to do it for reasons other than this. For example, this is the TB granuloma with cataract in a young girl. Everything has been tried. So some of these patients, if the anterior chamber is good, you can do a combined surgery. And you can see always a small gauge and always suture the wounds in uveitis. The initial samples are obtained under the air, and subsequently you go on, and this is the post-op. I will not go into on surgeries because Mudit has already told most of the things. Just to reiterate, like PVD needs a very gentle handling in on. So please do not induce the PVD you will do in other settings. I would rather not put triamcinolone for the staining, and the mild edges at the active end of the lesions in the healthy retina, like Mudit said, and no laser over the active patches, 5000 silicon, and the membranes like this. Sometimes you need to leave them where you cannot pull it. Don't pull it to cause more damage than already. So this is like post-op Farhan. These patients do actually very well. And the last is, many a times you may have conditions like this, TB with fibrosis and all, but you can achieve. I think conclusion is you have to be very meticulous with the planning and know what you want to do. And it's not only the surgeon, your entire team, cytopathologist, molecular biologist, the person who's going to take the samples. I think they are much more important than the surgery, because otherwise surgery is just like a plumber doing plumbing. So it won't give you the answer for uveitis. Thank you very much.
Thank you, madam. Just time for one question from the panel, if any. Otherwise, we hand over the session to the next team.
Okay, perfect.
Thank you. Thank you, everyone.
Take a photo.